to the ACR Bulletin Podcast, the show where we examine the latest trends affecting radiology. I'm your host, Chris Hobson, and today we'll be talking with Dr. Aalpen Patel. Dr. Patel is a physician engineer and diagnostic and interventional radiologist with Geisinger Health System in Pennsylvania. He serves as chair of radiology for the system, as the medical director of artificial intelligence for the Steele Institute for Health Innovation, and also leads imaging informatics in radiology. Dr. Patel, thank you so much for joining us today.
Thank you very much for inviting me, Chris, and look forward to the discussion.
Absolutely. Well, let's dive right in. Today, we'll be talking about your team's efforts at Geisinger to combat overutilization of imaging, and relatedly about your unique approach to using clinical decision support, or as some people know it, CDS. But first, why have you all, I'm really interested to know why you all have taken overutilization so seriously at Geisinger. It sounds like maybe Geisinger offers its own health plan to patients. Maybe that has something to do with it. But could you please elaborate on that for us?
Geisinger is an integrated healthcare delivery system with 10 hospitals and an insurance plan that covers approximately 600,000 lives. So our goal in that setting is to perform the right imaging at the right time and reduce unwarranted variation in care. Of course, it's not an easy issue. And as an idea with an insurance plan, we look at revenue a little differently for radiology. So we don't look at it as isolation. If there is overutilization, it can increase revenue for radiology, but it also increases expenses for a health plan. So therefore, it's not a net gain for the combined enterprise. Those additional expenses also makes us less competitive in the insurance market and potentially impede growth. So that's the way we're looking at it. And of course, one way to address this overutilization is to use accepted evidence-based clinical guidelines to guide some of the decision-making. And benefit of taking this approach, of course, is potentially improved outcomes and reduction in cost of care. And in many cases, reduce unnecessary radiation exposure for our patients and members. We realize this is not really easy to do, but it has to be done. And we're just trying to find a narrow pathway that's going to work.
Excellent. And, I guess when you say IDN, are you referring to integrated delivery network? Is that what?
Yes. Yeah.
Okay. Yeah. And I guess in keeping with that, it's not like just to set audience expectations. A lot of what you all have done is pretty unique. And I don't know that it's totally scalable in all situations. But nonetheless, we find it really interesting. So we're just really want to find out more from you on how you did this. So I guess that brings us to clinical decision support, or again, CDS. Again, as we were talking about before we even started, CDS is a little bit fallen off a lot of people's radars just because of the ongoing health emergency and PAMA being pushed back and back and back, which we'll come to in a little bit about the more context of that. But for now, it's a tech. If we can maybe remind people, it's a technology that does help stem overutilization. So maybe for our viewers who maybe aren't even very familiar with CDS at all to begin with, can you please provide a brief explanation of what it is and why you find it important to radiology?
Yeah. So from a radiology perspective, there are two broad categories of CDS. One is for radiologists for clinical guidelines and so on. And the other one is for the referring physicians that supports the ordering patterns for the referring physicians. So in its ideal state, within that scenario, a CDS would help referring providers order appropriate tests for the patients for a particular clinical scenario. So we're trying to achieve that by using CDS mechanism that delivers that particular guidance in the least disruptive way as possible within the ordering workflow. From other prior experiences, we found that the more disruptive the workflow is, and this is a pretty well-known fact, there's less buy-in, and then the last thing people want to do is to do more clicks. So we've taken made significant efforts to reduce some of those clicks. And the way our CDSM tool works is the provider types in the usual study for reason, the reason for study, I should say, within the AMR, and then the tool performs NLP on it. It structures that indication and then interprets the indication and renders a judgment. If it doesn't have enough information in, It'll ask for additional information to help support that. The other thing it does, which is pretty unique, is that if there's a note associated with it, it will actually read the note and try to support the indication as well. So so it does a lot of things to support the referring physician, so that they don't have to do extra work, and they will only do extra work if it's absolutely necessary.
Yeah, and I know that's a big concern of CDS adoption at the foundational level, is not giving referring physicians more work to do. You want it to be integrated. So I love that idea of trying to keep it as seamless as possible, is what it sounds like you're saying. So
Absolutely, and that works pretty well in a closed environment, right? So for Geisinger physician within Geisinger environment, it works. But we're also working with our working to give same access to our external partners, non-Geisinger provider partners, with a gateway, or giving them access to Epic Link that will log directly into our EMR, and they can put the order in right there, and therefore get the support they need there as well. So we're communicating this and supporting our partners with our physician liaison team.
well, that's great. That's great. It sounds like it's very inclusive. So that's a good
Yeah.
thing. Well, one reason you and your team have pushed ahead with installing CDS, despite, like we talked about, the ongoing medical emergency and things like that, is because of I said PAMA off the top. I should have probably defined it as the Protecting Access to Medicare Act, that piece of legislation that came out in 2014. So can you please explain how that has influenced your approach to CDS implementation?
Sure, of course. So as a brief review, PAMA, or Protecting Access to Medicare Act of 2014, and in particular for radiology, Section 218B, mandates that for advanced diagnostic imaging like CT, MRI, PET, and nuclear medicine, all orders have to go through a qualified clinical decision support mechanism that uses guidelines from a qualified clinical or provider-led entity. So in that light, majority of the CDSM are using different guidelines. Some are using ACR, some are using all different kind of guidelines. There are, for the implementation phase of it, there are two phases of it. One is the educational and operational phase, where it allows you to implement, experiment, and make sure that the mechanisms are working, and allows you to educate the referring providers so that when you go live, when I say live, I mean the second phase, which is the penalty phase. You have less issues. And the idea here is of the penalty phase is that if you don't go through such a mechanism, the imaging service provider, meaning radiology, would not get paid for the study. So that's why it raised a lot of antennas and focused people on how to implement this. And this phase, of course, has been postponed indefinitely, and we don't know when it's going to start back up again. But regardless, we're going to continue our efforts. So CDSM does two things. One is that says, does it adhere to appropriate use criteria that is determined by the qualified provider-led entity? So if it does it adhere to it, or it does not? It doesn't prevent you from actually ordering it. It just documents adherence. And there may be areas where there is no AUC for that particular clinical indication, and they'll document that as well.
So interesting. Well, maybe PAMA is a good backdrop for my next question, which is, how did your team obtain executive buy-in for even using CDS? Because I know sometimes it's a heavy lift for some hospital systems.
Absolutely, and the postponements have happened, and it has helped in some ways. But PAMA itself, the act, the Protecting Access to Medicare Act, helped us drive some of the buy-in. And on top of that, our executive leadership and our health plan leadership already tracks some of the utilization data and benchmarks. And that already we led to a conclusion that CDS is needed regardless of whether PAMA exists or not. That means that we need that particular guidance to control and appropriately size utilization. So regardless if PAMA happened or not, because we track some of these utilization data and benchmarks and compare them to benchmarks, we already had buy-in. And so our executive team has been a big supporter and a believer of this effort. And as a matter of fact, they've tasked me along with our chair of emergency department to lead this effort and continue that effort indefinitely.
It's so interesting because I've always, ever since its inception in 2014, I've always thought of PAMA as more of a stick than a carrot. It's like you get penalized, if you don't go, seek out the appropriate kind of guidelines and things like that pertaining to, Medicare patients and things like that. But the way it's so interesting, the way you're approaching is more of a carrot in a sense, because you've almost, it seems to me like you've helped, PAMA maybe helped you get you there. But I mean, now that the executive team understands the importance of it, it almost doesn't seem to matter in a sense that PAMA has been suspended. They really are hooked on that idea. Do I have that right?
Yeah, absolutely. And this is not an effort that started now. This is something we've been trying to do for a decade. It's just some of the mechanisms that we're using are more mature for us to do this. So we participated in the original MID, or the Medicare Imaging Demonstration Project, about a decade ago. And from that we implemented a different mechanism probably 5-6 years ago, and that was probably perhaps a too broad a scope. We included all orders and the inpatient, outpatients, and ED. So that was probably a too broad a scope. So now we've sort of appropriately sized it, limited to PAMA. And once that is mature, we'll expand it. We'll probably call it PAMA Plus or something, for lack of a better term. But that's something that we intend to do.
Yeah, well, and the fact that you started so long ago, some people might see that as intimidating. Like, oh gosh, we haven't even started, and it's these I guess super users, if you want to call it that, of CDS. It's taken them 8 or 9 years to really get up to speed. But I mean, how would you? I know we didn't talk about this ahead of time, but do you have any advice for somebody who might be facing this? Like, oh, I really, whether or not PAMA is a real thing to them, they still want a radiologist maybe out there or two who are watching really are energized by this idea. I mean, it's good to to set expectations that this isn't going to happen overnight. But how would you encourage them to get up to speed like that?
Yeah, I think so. Starting small and focused is number one thing, and the second is achieving buy-in from your partners who are ordering these studies is going to be big, and for that to happen, you got to make it painless for them. So that's something that if you ask them on an everyday basis, providers are asked to do different and more things, and if this is perceived as just one of those things, then it's going to be difficult for you to get buy-in. And the next is tell people why we are doing this, and the why will support your efforts as well. And I think that's going to be critical, and that's what we did.
That's good advice. I hope people take that to heart. Well, as I understand, and you talked about this, you alluded to it earlier, the educational component of what you've done is very important. So I was wondering if you could talk a little bit more about that, the education vis-a-vis your implementation efforts, and kind of how that worked, or maybe if it evolved over time. If you could enlighten us on that.
Yeah, so because we did multiple iterations of this, we learned a lot. So education is, of course, paramount to move the needle on this issue. And our educational approach has been learning from our mistakes of the past, is layered and ongoing with active periodic engagement. So we started first with leadership meetings where clinical and operational leaders meet and started and answer their questions, right? Because they're going to have to drive some of these changes as well. And then we attended departmental or faculty meetings for education, for departmental adherence data sharing, and for question and answer sessions, because anytime you ask people to do something, they're going to have questions, and we wanted to make sure that we are telling them why we're doing that and how we're trying to make it painless for them. And they knew what the other implementations were. So we told them that we hear you. It's going to be less painful than that, and it's going to be much more streamlined. So that's how we were able to achieve buy-in. So education is absolutely very important. And the next things, as we did more of this engagement, we learned that some of the workflows are much more complex than what they should be theoretically. So as we learn them, there are nurses scribing orders. Well, our initial education plan did not include nurses. Now we're including nurses in that. Or, of course, residents were included, and we educated residents. But as we learn some of these nuances of the workflow, we educate those folks as well.
So interesting. It's an iterative, flexible process, it sounds like.
Absolutely.
If I were to put it in a
And the second part is that we meet with each department lead every month, present them with data of adherence and non-adherence. We give them a Pareto of who's the top adherent folks, so we can give them kudos, and who are the least adherent, and we can that particular leader can then have a conversation with that particular set of providers and say, and do a non-punitive education, right? So this is about education and not about penalties. So so that's the other thing, and perhaps connect the people who are doing well with those who are not, so for knowledge sharing. So those are the kind of things. And we've discovered issues with this. So when we, in some cases, we look at some of the charts together and say, what is going on? So for our transplant program, we discovered that they were getting flagged for ordering a lot of the cardiac imaging. But they were ordering cardiac imaging because these are pre-transplant folks, and they need to have that risk assessment done for major operations like that. So that's within a protocol, and we shouldn't be penalizing for that. So we'll work with the vendor to make sure that those are dealt with appropriately, and not and they don't get dinged unnecessarily for it, because they're doing the right thing for the patient.
And that's, so it sounds like it's an iterative process, and you're collecting data, just even in and of itself, on how people are learning. Who do you have? Somebody who's tasked with collating all that, collecting it, and reporting it, or is that just something you've taken on yourself?
Yeah, these are
process.
So this is part of our transformational process. So we have a couple of team members from the transformation team that helps us collate some of these data so that we can share.
Interesting. Yeah, that's because I was like, that's a big task if you yourself are also taking that on. Well, yeah, and we'll talk about the adherence rate in a minute, because it has jumped since you've been doing this. So, but first I was wondering, and you've touched on it earlier, but I'd love to get some more detail around, how you keep the C-suite updated on your efforts. Sounds like you talk about data, you present that data regularly to administration stakeholders. And I'm just wondering, how that process works, how it even got started, and kind of how you handle that, and how regularly you do it.
So our institution is broken into departments and institutes. So there are institutes have multiple departments within them. So when we have this, so our institute, is Diagnostic Medicine Institute, has two departments within it: radiology and lab and pathology. So when we meet on a bi-monthly basis with our C-suite to talk about a variety of things, we report out these efforts during that time. And then on a quarterly basis, we meet with our executive leadership team to report out the performance improvements that have happened, that highlights the efforts of referring physicians, as well as the associated financial impact in the metrics as well. So, and if there are barriers, we communicate with those as well, and jointly figure out a way to overcome those barriers.
So it's a very data-driven effort, and it sounds like all parties are kind of bought into that idea. So
absolutely, and eventually we'll probably have each institute has its dashboard, so eventually we'll put those data on those dashboards as well, so that those are highlighted as part of the review process for their meetings with the executive leadership as well.
And is that sort of, I'm sorry if you said this, but do you, beyond just the C-suite, do you publish that internally? I know you said you're getting ready to do dashboards, but is there any way of sharing that?
There's a significant amount of data here, and what we wanted to do is make the process very easy for our department leaders. So we've created our data team has created a single pane of glass dashboard, so that when they look at it, it's going live at middle of this month. We already shared some of these on these monthly meetings, to make sure we're addressing people's needs. So based on those feedback, we have modified those the dashboard, and the final iteration of it we're about to publish in a week or two.
Wow, that's
That will
wonderful.
be available on our analytics dashboard, and that's one thing, right? That's for leaders. But eventually, when it's mature, we'll actually open it up to everyone. So anybody
Wow.
can look at their performance. Transparency is something that will drive quality, right? So
That's interesting.
do that, yeah.
Yeah, and you know, little competition never hurt anybody, right?
Yeah, sure.
That's good. Well, we talked a little bit earlier about the adherence rate of CDS having jumped. As I understand it, it's gone from 51 to 60% in 1 year, which seems to me like a big jump.
Yeah.
How are you planning on building on that success, you know, in the coming years?
Sure. When we first started, it was about 51% in January. And it has climbed. When I told you last time, it was about 60%, but now last month's data is up to 64%.
Wow,
Hopefully we
climbing.
sustain that or improve that. So we continue to move in the right direction over the year. And our playbook really isn't going to change because it has worked successfully. It will continue to make make the engagement with CDSM easier within the EMR. Continue the effort with our CDSM partner on NLP front, as well as even giving people positivity feedback, right? So if they did a particular test and 99 out of 100 times it's negative, they should know that, right? So they can recalibrate, at least mentally. Continued feedback on to department leaders who in turn provide feedback to their team members, and just continue to listen actively so that if there are issues, we work with them to fix those issues. If the tool isn't working, or if the tool is preventing appropriate engagement, or whatever the issues are, we understand those, work with our CDSM partner to fix it.
Excellent. And it sounds like you've got a pretty open line of communication to the IT folks who are supporting these efforts. Is that important as well?
Absolutely. So that team meets with our partner in a separate fashion, along with our CMIO, our Chief Medical Informatics Officer, on a monthly basis. So there's an open line of communication with our CDSM provider.
Well, bringing this back to PAMA again, ever since its inception, PAMA has been somewhat fraught, as we've talked about, with delay after delay of implementation. So can you please talk about where we are right now with PAMA?
So currently, we're in the educational and operational testing phase. And that will continue per CMS until they say no. So data tracking phase, what this implies, will continue, and we'll continue to gather data. And in our case, we're using those data to act in the manner that we just talked about. The penalty phase has been postponed again, and this time due to public health emergency, and we don't have a forecast from CMS as to when the penalty phase would begin. But if I had to, if I had to use my crystal ball, it's probably going to be, just learning from the past, probably be a year after the PHE is over.
Oh, interesting. Just to give you, so that's encouraging for people who maybe haven't gone very far down this road. We're still in that education and operations phase. So maybe now is a really good time to get in on this, because it may last for up to another year or so. Well, Dr. Patel, it's been such a pleasure speaking with you today. Where can people find you online if they'd like to continue this important conversation?
Well, thank you for the opportunity, Chris. It's been a pleasure. My email is aapatel@geisinger.edu. That's 2 A's, aapatel, Patel, @geisinger.edu. And I'm also on LinkedIn.
Thank you so much. And for our viewers, if you have any ideas for future show topics, please let us know on Twitter at Radiology ACR, and please use the hashtag ACR Bulletin Podcast, all one word. I also invite you to check out all of our past episodes at Apple Podcasts, Spotify, Google Podcasts, and please be sure to subscribe to ACR's YouTube channel to see our latest episodes. And please do also hit that like button if you found this video valuable. So thank you so much again, Dr. Patel. We'll have to have you back, and hopefully you'll be able to update us on CDS and all things appropriate criteria in the future.
Absolutely. Look forward to it.
Well, thank you to our listeners. This has been the ACR Bulletin Podcast. See you next time.